So the title's called How to Reduce Dissections and BTK Interventions, but I think what a more appropriate title would be is How to Limit Injury, because, of course, if you do angioplasty, you're injuring the vessel. So those are my disclosures, haven't changed. So when you're looking at the problem and potential solutions, I think it's always important to understand the complexity of the lesion. I think it's always important also to understand the mechanism of action, because again, you're injuring the vessel, so you just have to decide how many times you want to injure a vessel to help it. And then look at things that might help. So is there anything to the PTA technique that may help? And then are there adjunctive techniques that help? So Fadi's group did a great job of looking at the complexity of BTK disease in this publication. And to no one's surprise, these are very complex patients. Lots of Rutherford 4 through 6, lots of calcium, lots of occlusions. And the reason why that's important is you have to know going into it that we're still not where we want to be. Primary patency at 12 months is 63%, and this is like 52, 53 studies they looked at, and the amputation rate is still not where we want it to be. So there's a significant challenge. So understanding the complexity of the lesion, I think this is where we've been talking extensively over the last couple of days about imaging, whether it's external ultrasound, intravascular ultrasound, but just getting into the using some sort of system to assess just how bad a lesion and how challenging a lesion we're talking about. So whether you like the PARC system or the PAC system, just familiarize yourself with one or the other so that you understand what you're getting into, because it will play a role in what equipment you're going to choose. The other thing is understand the mechanism of dissection, and this is not just for CTO, this is just in general. So if you're using short balloons and you're doing multiple overlaps, you're repeating injury, and you're repeating injury at the overlap sites, and it's going to make it very difficult to avoid dissection. Now, is there something to using a long balloon versus a short balloon? Well, in this study, there was. So if you look at severe dissection, if you were able to use a long balloon, i.e. trying to get on either side of the lesion or the occlusion, you had significantly less severe dissection. And in terms of pattern of dissection, this was an SFA study because there is no below-the-knee study, but you see that the severe dissections were actually quite severe when you compare 177 millimeters in length to 54. And when they looked at all the variables, it turned out that if you had a long enough balloon, so in this particular instance, greater than 220, that was a single negative predictor of dissection. So long balloons do matter. What about inflation times? If you leave the balloon up for a long time, does that matter, or short time? So it turns out that if you look at the C through F dissections in total, if you had a balloon time of 4 to 10 minutes, and I think PK was just saying he was going to leave it up for 8 to 10 minutes, then that also showed a significant improvement in your chance of having a severe dissection. So long balloons, long inflations help. Does anything else help? Well, there's promising data here from intravascular lithotripsy. You had an SFA trial, the Disrupt PAD study, where you had a nice lumen gain by disrupting the pattern of calcification. You only had one dissection, had pretty good TLR at 6 months, and this was more or less replicated in a small study, but the Disrupt BTK study, I think, still is promising in terms of what you can achieve by modifying the plaque and limiting your chances of dissection. What about other devices? So if you look again at serious dissections, in this study, you had mostly orbital atherectomy, but you had a combination of rotational aspiration or rotational with cutting and aspiration, and atherectomy seems to help as well. So again, if you can just get away from blowing up a balloon in a complex lesion and watching it crack and spiral both directions, I think you'll be able to limit your dissection somewhat. And in this study, atherectomy was the only variable associated with decreased dissection. So long balloons, long inflation times, lithotripsy maybe, atherectomy, definitive LE, the infrapopliteal group you see is representative in terms of calcification and long lesions, and you see a dissection rate, at least flow limiting, that's actually pretty impressive considering the problems that you can potentially run into with directional atherectomy below the knee in terms of adventitial cuts and so forth. And then, just to keep the theme of IVUS going, if you use IVUS with your DA, it seems to help even more when you look at TLR as evidenced in this study. So in conclusions, BTK intervention is complicated. These lesions are complicated, so there's lots of things to think about. The long-term results of just plain balloon are suboptimal. Imaging can help. Long balloons and long inflation times can help decrease dissection. And adjunctive therapy, according to what you see in the lesion, such as atherectomy and other calcium modifying devices, can also help reduce dissection rates. Thank you.